Okay, now I need to drop these off in admission. And they're like, what did you bring?
I'm just more support. So you guys can see my face too.
We're gonna share this and I was like my laptop. No. I was like pointing out. There's an internal struggle. Yeah. Sora. Elena Sarah. Yeah. Yes, I'm so jealous. She's bad at it. It's like so much fun. I really want to use like sensitive so I can send it to my dog. I used to do it. Something like that. She's keeping us away from
Oh my God. Be nice. Be nice.
Hey guys, there's chips here. There's barbecue, chile and lime, and regular, and there's a lemon dip. So grab them.
Thank you, Miss Lee.
Whoa! That was a whole motion going on there. Everyone wait, has the chocolate. Okay, I'm gonna go down.
Except to the
Come back.
Miss Lee, happy birthday. No problem.
So what is this?
That's caramel.
Oh.
So they're all yours.
I've been doing good.
They say sugar is really, really good.
neat, like a new shoes. Thank you.
I do notice it like in my own
I literally just got them yesterday. Good feeling. I like that they don't have laces. Yeah, I got them from Costco. They're good support around here. Yeah, I think so. I feel like they're a little bit wider, and I have like a little bit of wider foot. So
Good morning. Should we put this over there?
not like the best of the best. I didn't want it to match.
It's like, I never realized that when
You go to Mexico next weekend, right? Oh, yeah. Oh, this weekend you go to Mexico.
Friday.
What's the first one in New York? Yeah, I think everyone will like this one.
You don't have to use coats or something. They have
You guys wearing hats together?
No. I was his teacher.
Oh!
No.
No, that's good. Oh, wait?
Not true. Definitely.
That's what they announced.
That's a lie. It's total lie. Because one of our faculty who was African American for me. She taught me.
Male?
Female.
Maybe we're
That might be true. We have a lot of us there.
I woke up and the scrubs on, and I'm like,
Nope, it's not the only one. It's another one.
we decided to.
That might be true.
I was like, I can do this starting
But I know there's other things.
Monday. Like, you can throw it. I can't do both.
You don't want to be a surprise, but
Oh, I'm gonna do it Friday.
They look the same.
I did it last Friday. I didn't do it Friday.
Like the last one.
That's why they're being all touchy-feely. Crying the whole time. Like, on the first day. Like, people are gonna die.
I felt like there was a lot more. It's like weird questions. What's the experience? Like the basal thing, they're like histology.
Oh, yeah.
Like trying to listen in my head, like the basement membrane.
This has a
Talk to him, see what he says.
like the first 2 weeks, it did.
My brain. I'm just pushing all of it.
that one?
Your eyes are way
It wasn't difficult, but it was, or it wasn't hard. It was
I'm on a roll today. Thank you for your honesty. I wanted to do it. I'm sure you're
Alrighty, good morning, guys. Welcome to class. There's a method to my madness with the potato chips. Welcome. I didn't know you guys used so much brain cells in your midterm that you were just ravenous for these chips. I'll have to do this again. So I got part of this story. I just knew I had to get chips for today because I was reading this story, but I missed part of it. So my apologies. Maybe we'll do another one at a different time. So, a little boy wanted to meet God. He knew it would be a long trip to where God lived, so he packed his suitcase with a big bag of potato chips and a 6-pack of root beer and started his journey. I forgot the root beer, but that's okay. We got chips. When he had gone about 3 blocks, he met an old man. He was sitting in the park, just staring at some pigeons. The boy sat down next to him and opened his suitcase. He was about to take a drink from his root beer when he noticed the old man looked hungry. So he offered him some chips. The man gratefully accepted it and smiled at him. His smile was so pretty that the boy wanted to see it again, so he offered him a root beer. Again, he smiled at him. The boy was delighted. They sat there all afternoon, eating and smiling, but they never said a word. As twilight approached, the boy realized how tired he was, and he got up to leave. But before he had gone more than a few steps, he turned around, ran back to the old man, and gave him a hug. He gave him the biggest smile ever. When the boy opened the door to his house a short time later, his mother was surprised by the look of joy on his face. She asked him, "What did you do today that made you so happy?" And he replied, "I had lunch with God." But before his mother could respond, he said, "You know what? He's got the most beautiful smile I've ever seen." Meanwhile, the old man, also radiant with joy, returned to his home. His son was stunned by the look of peace on his face, and he asked, "Dad, what did you do today that made you so happy?" He replied, "I ate potato chips in the park with God." However, before his son responded, he added, "You know, he's much younger than I expected." Too often we underestimate the power of a touch, a smile, a kind word, a listening ear, an honest compliment, or the smallest act of caring, all of which have the potential to turn a life around. People come into our lives for a reason, a season, or a lifetime. Embrace all equally. Have lunch with God and bring chips. Each one of you have been or will be God to someone in your chair. And maybe one of your patients will one day be God to you that day. I've had a lot of people go through a lot of experiences and share all of those in my chair. When you work for a very long time, especially in the same office, you're going to start seeing the same people over and over and again. And one of the experiences that I remember was a young girl. She was probably a teenager when I first met her. And I watched her go through high school, and I watched her go through college. And I watched her become one of my dental hygiene students. I watched her marry a dental student and off to San Diego to practice dental hygiene with her husband. That brings the greatest joy because somehow, some way, I must have influenced her to want to be a hygienist. And here she is, and she married a dentist and the whole bit. You get fun, cool stories like that. And you'll watch patients give birth. You watch your own patients pass away. And that becomes sad too. But the greatest joy are the people in the lives that you're going to touch, and it'll be so fun, and they will touch you in return. So enjoy your patients, each and every one of them. Prayer requests for us today. Everyone had a good Easter?
Yes.
Yes. I know you studied hard while you were doing that, but anything special? Any other midterms coming up this week? Pre-clin tomorrow. We will pray for that. Okay. Anyone else? Let's bow our heads. Father God, as we're munching on potato chips this morning, thank you so much for the gift of touch, the gift of an encouraging word, the gift of thoughtfulness and kindness. I pray that you'll help each one of us to demonstrate that this week. And may it be demonstrated back to us. I pray for these students as they study this week for their midterm and pre-clin. You will be with each one of them. Help us to have a good class time today as well, and to learn new things that we can apply to Clint. We pray in your name. Amen. Okay. I know you're still munching away, so while we're munching, before we take our quiz, I want to talk a little bit about clinical experience. Is there anything that we need to address, bring up? Things that changed a little bit, modified? How many of you took vitals first? Before you did your update on your health history? No? Good. Good. I did send an email out to the faculty, so hopefully that will help. Anything else clinically? Yes.
Taking vitals first, taking the medical history first, is that something new that you implemented?
Nope.
Okay, because I did that last week, and the senior who assisted me, she was just I guess it's not something that they were aware of.
They were aware. I gave them the same quiz and the same lecture and the same clinical protocol. So, yeah.
No, I was actually really happy that I experienced the benefits of doing that last class period. And I have a question about
Why did you experience? What did you experience?
well, the patient was saying that they don't really have hypotension apparently. That's what they're saying. And the results in their paper that they get from their doctor, it says like their blood pressure was 129 already. But then, as we're talking, they're exercising. But when I take the blood pressure vital at the very end, it shows that they are, at risk for hypotension. And so, I took it twice, and then my instructor took it just to make sure, and it was high. Is our blood pressure, is ours more accurate than the ones they do in the hospital?
So here's the deal. Sometimes when you're at the doctor's office, dental especially, it's unusually high. It's what we call white coat syndrome. Have you heard about that before? So sometimes people are just stressed out, especially dental. When you're at a medical appointment, they're usually checking here, checking there, doing this, or asking a lot of questions. When you get invasive into someone's personal space, they get tense. Dentistry is one of the harder and most difficult jobs, is working in that field. The suicide rate for dentists are amongst the highest in the nation.
Why is that?
Why is that?
To me, you're working in a space that big, on a tooth that big, on a place that you can't see, in a place where people don't want you to be, and you're trying to be very precise, cutting that box or whatever else. It's difficult. And to manage tongue and saliva and materials that can't get wet or whatever. And you'll find that when you start doing sealants, you're trying to focus on this tooth, on this surface, and you got to get it, and the saliva's everywhere, and somebody's coughing and choking and blah, blah, blah. People don't want you there. It's a hard profession. What you do is difficult on people who don't want you to do it. Some people have told me they'd rather have a baby than get their teeth cleaned. I'm thinking, really? Clean my teeth anytime. But I've had people tell me that. I'd rather have a baby than get my teeth cleaned.
So it's difficult. It's just stressful for people.
So, so mainly it's from stress and not being liked? Professional?
It's everything that you're doing. Hand-eye coordination, making sure, getting the place that you're working, keeping it dry, cutting the box in a tooth that big, and this, it has to be. If they don't cut that correctly, the retention for the material to stay in there will pop out if it's not cut properly. Just a lot of things. Lucia?
Also, how do I know the fine line between when I should pull out my Cavitron or I should just stick with hand scaling? Like, okay, I'm just gonna, should I look at the clock and, okay, I don't know, I get confused with that.
Anybody have the answer to that?
Cavitron.
Me? I don't work on anybody without a Cavitron.
You start with Cavitron.
Absolutely,
always first.
absolutely. So that's my number one thing to pick up. Okay, because yes, you do need to get your hand skills up, but you need to learn how to use the ultrasonic properly. It takes about 1 year to use it well, and then to pick up what's left from that ultrasonic. Okay, you shouldn't be working in an office that doesn't have one.
Because my instructor was like, just do the hand scaling.
Yeah, same.
So tell me the benefit. And it's not a test. What is the benefit of your ultrasonic? Does it do more than just remove calculus?
Yes.
Yes. And why wouldn't you want to do that for your patient? What are you doing? You're killing cell wall? What? Flushing out?
Yeah.
You're doing a lot of things to the bacteria in the pocket. Can you get every bit of that bacteria out of the pocket by hand scaling? No. And it's superior in furcations and in deeper pockets. So I pick up the ultrasonic first, and I don't say, oh, do you want me to use this thing? I tell them, what I'm going to do is use a warm water spray to go around and flush things out from underneath the gum line, and then I'm going to go in by hand and smooth up the surface. Then I'll polish your teeth. I keep it simple. If I know I'm going to do a simple probe. And I'll be able to finish.
If our clinical supervisor advises us against it, do we have a right to say that we want to use it, or should we
Yeah, you do. You do. You know, if they have a problem with that, just say that we've been taught in our class, our pre-clin class, and our clinical seminar class, that we should flush out the pockets first. Because you know when you're scaling and you're hand scaling, you're just hand scaling plaque, it's time consuming because you're scaling, you're wiping, and you're scaling, and you're wiping. It takes too much time. Why should you be doing that and then repetitive motion on top of that? So you have good argument for using it. It's all in the literature. And just say. And if you have problems, that's what we've been taught. Go talk to Ms. Lee. Go talk to Ms. Lennon. Okay, we all pick up our ultrasonics first, all of us in private practice. Why would I want you to do something different? Just to make it hard for you? I'm not about hard. I'm about making it easy. Someone else over here had a question? Any other clinical issues, questions? This is what I want to know. Yeah.
I have a question. We were taught how to give. Oh, sorry.
Because they can't hear about you.
Yes. We were taught how to do injections from our dominant side. What about non-dominant
You're
side?
going to learn that.
Okay.
Practice it. So some of you know that if you've had me for an instructor, I've said, if you don't have a patient and you don't have any comps on the perspective that you need to get, and you'd like to practice anesthesia, you're more than welcome to do that. Practice your dominant side, practice your non-dominant, because you can't pick and choose, especially those of you that have already started some root planing. I know several of you have gotten some scaling root planing experience. Once you finish your dominant side, what are you going to do? You don't know how to give an injection on that side. You better practice. So get out your syringes and practice. Find some time. Sometimes it's Friday afternoon. Sometimes it's other times when you could get a small group together, maybe 4 of you, and get an instructor and say, hey, do you have a moment to just help us with some fulcrums for this? Or where are you going to fulcrum on a non-dominant on a PSA or IA? That's difficult. And if you've never practiced it and then you have to do it in clinic, that's hard. So You are going to be tested on the non-dominant side. I believe that's in June, if I'm not mistaken. That's the anesthesia testing. So good question. Yes.
If my patient needs radiographs, and they just recently had what is called a UGI, which I'm not familiar with.
UGI?
It's some type of like chest scan.
Okay.
Are they still safe to give radiation to?
Okay. So in class, I'm gonna think this through. In class in radiology, about how much radiation would it be in FMX? Minimal. So if they've had a chest x-ray of some sort, is it okay to give it FMX?
Okay.
Yep, it is. Anyone else? Clinical. Open it. The floor is open for you to ask any clinical question. Sarah. Uh-huh.
For the patient, there's some implants and bridges. So should I stay on a booster or I can go back?
You can probably for an implant, so that's a good question. Sarah's asking, if I have a patient with an implant, where can I be on my Cavitron, stay in the blue zone? What will probably be around the implant? Will there be plaque? Okay, likely plaque. Will there be calculus? Not generally, but sometimes a little bit. Okay, so depending on what you have, if you're deplaquing, flushing out should be fine in the blue zone. And you can go a little higher if you want to. The only thing is heat. Just making sure you're keeping it cool, making the water go through. And remember, for those, you have to use the little sheath on the plastic sheath that goes on for implants, so they don't scratch. Naveen, did you have a question?
Yeah, that's what happens sometimes. Even when I'm doing it right, they won't reheat. And I try to take it out, bring up the water again.
You don't have to bring up the water, just turn up your water dial a little bit, or on yours it's on the handle, just increase it just a little bit. Okay.
Just increase water.
Just it needs more water coming through the tip. Yes.
I was working with my Cavitron yesterday, and like I plugged it in and everything in the lab, and in the bone, and I turned it on. So I turned on the power, and I wasn't pressing the pedal at first. Well, no, I started pressing the pedal and I was going to work, and the light turned orange.
Okay. Did you not talk about that orange thing?
The boost.
Okay, that's your boost.
Okay.
So when you push down the pedal like this, we get you on your regular light, okay, that it's on and it's going. If you push it down a little further, now you shift it into higher gear. It's about 25% higher. So when I'm scaling, I go along and I'm scaling with my ultrasonic. And by the way, it's USS, not UUS. I saw some people on the discussion board. It's ultrasonic scaler, USS. Okay, so I'm scaling along and I come to a harder piece of calculus, boost. Knock that piece off, come back off your boost, and just keep going. Okay, so if you come to that harder piece of calculus, making sure that that's, and then just come right back off. So that's what that light is. It's your boost. Anything else? No clinical questions? How was treatment planning this week? Better? Much better? Okay. Is there any questions on treatment planning? Good. Yes, Sarah.
So if, for example, my patient, she was here in September and she mentioned some medical stuff. And that was there. But since I asked her a question regarding those, she said, no, I didn't have that. Should I use them?
You're talking about medical history?
Yes.
Okay. So Sarah's asking, the patient was here in last fall, and there were some questions on the medical history that were marked. And then she asked her again this time, but she said, no, I don't have that. So can you give me an example of what it was?
It was about the bone surgery, and she had it. And she said, no, I'm okay, I didn't have that.
Bone surgery in the jaw, on her back. Okay, so she may be saying, I had the surgery but I have no residual problems from that. And that's all. It still stays in the history because it's part of her history, but there's no residual problems for that.
Is there gonna be any protocol change for the MI pace?
Yeah, you saw that email at MI Pace? So one of the questions, if you have not seen that email at MI Pace, there was a death, I believe it was in Orange County, by some dentist prescribing MI Pace to a patient. MI Pace has a casein base, which is a milk product. She has an allergic reaction, an anaphylactic reaction to milk. The dentist never told her that there was a milk product in it and prescribed it to her, and she died after using MI Paste. So we're not changing that, but you need to be aware when you're prescribing the patient MI Paste. Like when you're prescribing penicillin, do you have an allergy to penicillin if you're prescribing amoxicillin? No. I'm prescribing, I'd like to give you some MI Paste for the sensitivity. Do you have any allergies to any milk products?
Not lactose though, right?
Not lactose intolerant, a true allergy to milk product. So yeah, I don't think protocol's changing, but we need to be aware. It was a good reminder for me even. Oh yeah, that is milk based. You know, and I'm sure it was a sad day for that family and the dentist that's prescribing that. They probably forgot too it had a milk base. Calcium, casein.
Is there something that they're going to be able to sign that we make sure that we told them? Because what if we do tell them?
What do you have already signed?
The treatment plan?
Medical history. If they didn't give you the information, any allergies, you're covered. But you still need to ask. And then you can put it in the protocol. RX, MI Paste, no contraindications. So you can back yourself by covering that. All right. All right, let's close our computers. I think everyone's done with their chips.
I think we might have an extra. I'm not.
She has it. I know, right here.
The extras coming that way?
Yes.
Charlie, I'm in 1176. I'm trying to get a video clip to show up on the screen, but I won't be able to do that. Okay. My computer. Yes. I sent it to the projector, but it's Panopto. SH lead, S lead. You're about done? Okay, if you pass everything to the end. I just can't get it onto the screen. The camera looks like it's lit up. And I'm on the correct sources. It's plugged in. But there's nothing on the screen. It's dark. I don't even see the camera light. Not the camera, but the projector. It says it's on. I'm sending it Yes. But there's nothing on the screen. HDMI? Yep. I did. Black.
Yeah, you're gonna get. I'll go We're gonna worry about it
Take the break a minute. Someone here?
Oh, yeah.
I was in a car accident this morning. I forgot about that. No, I was in a car accident this morning. Keep in your prayers. I don't want to go over this until he takes it, but you're welcome to come to my office and look at what score you got and all of that later. I don't know anything about it. Barbara just told me as I was walking to class. Yeah, I'm not sure. I'm not sure about what happened or what. She got a call, so he must be okay that he called. So I will go over this quiz later. I'm waiting for the video guys to come over here to get that camera going because I have a video clip that we're going to do on OHI. Competencies now. Is there anyone that has not been able to get a competency yet? You all should have one, maybe? You haven't gotten any? A few? Okay, which is fine. But they've even maybe working on patients and not had an opportunity, which is fine as well.
Are we going to have a patient? Oh no, is there a chance that we could have a patient every clinic or
Absolutely.
so we might not have like a floater day where we
Correct.
can easily do a denture?
That's correct.
Okay.
That's correct. And you really actually want to have most of your clinic days going
Yeah.
and busy, so try and do that.
That's such a, some advice. I gotta have my patient counseled on me, and when you know that you don't have patients that day, try to get one of those non-patient comps done. For sure. Yeah.
So what's a non-patient comp?
Denture.
Denture comp, what else?
X-rays.
Radiographic eval, okay? Those are the kinds of things that you can get on those particular days, but you want to be scheduled every week as much as you can. It's nice to get a couple of comps, but one of those days, somebody's not going to come. And that's the day that you will get those competencies. Remember, by the end of spring quarter, you need to have 4. Okay, 4 comps. So if you haven't gotten any yet, start through that process. Arnett?
So my patient on Wednesday will be someone I know, and it'll be my family member, so I'm going to do injections. Is there a limit to how many we can do?
That question's been asked before, and what I say is it depends on what you're giving. For example, on an IA, you're giving a whole cartridge. On a PSA, you're giving a half. On a GP, NP, you're giving a quarter. So you could do more of those little ones than the. So I say be considerate to your patient. So maybe 3 or 4, depending on how well they do too. If other people are just there, just give what you need, but they're really uncomfortable, go with 2.
I was just thinking 3 maybe,
Yeah,
but I just
and that's
didn't
fine.
know if
That's fine.
there was too many to try.
Nope, it's okay. Okay, good questions.
So what if we have a patient where you know this patient's going to give you a hard time, like, oh my God, stop, know this, know that, they try and attempt to calm. Will their reaction affect your calm?
It's how you handle that situation. You just never know. You just never know what's going to happen when you get somebody in your chair. Whether I'm going to attempt it on AJ's dad, let's say. I'm going to attempt something on AJ's dad. I don't know how he's going to respond. You just do it and get through that process, and if it doesn't work out, next. So if that doesn't affect your grade, only how you handle what goes on.
He bites.
I've had people bite me before. Yes.
On purpose?
It usually occurs with kids or adults that fall asleep. Yeah, I've been bitten by adults that have fallen asleep. So yeah, you will get bit. You'll get coughed on. You'll get choked on. Water spewing. Yeah, that'll all happen. All right, I'm still waiting. Any other questions clinically? Experience. Does anyone have a really neat experience? If you haven't read Ariana's post about Grad Perio, you got it. You got to read her post in Grad Perio.
I just want to say I got to assist in grad care with a flap surgery.
So tell them what a flap surgery is.
Basically, they're removing the palate. From the palate, they're bringing it down and doing root planing on the roots.
So it's just like peeling back the gum tissue? And you're now cleaning your tooth right there. And they did a palatal with an ultrasonic. Yeah, it's cool. Perio's really cool. Oral surgery is really cool. Somebody else had a really cool experience in grad perio this week. Oral surgery as well, too. So I'm watching some of these good posts. In fact, Ariana, I actually sent your post to the department secretary in grad perio clinic because we've had a real hard time with grad perio in the past, and I told her this clinic block is a waste of my students' time. They don't do anything. All you make them do is clean your chairs, and they don't get to see anything, and blah, blah, blah. And I said, I'm going to pull them out of that block if we're not going to change this block. And so this was really told me that they're working it and they're making the effort for you to be able to see stuff. Because before, all you guys did was sit in a chair, and then when they needed someone to clean, maybe chart. But now they're really getting you involved in stuff and explaining what's going on. I think people are having a good experience. So I just told them, it's a waste of my students' time. You gotta let them see something. You gotta let them do something. So they're making a good effort to do that. Oral surgery block, are they letting you get in there? It sounds like it is. Yeah. Okay. And then your FMX, your radiology block. Another thing I want to clear up too, a lot of people, I'm looking at your posts and you're calling clinic lab. Clinic is clinic. Lab is lab. And here's where the confusion came. In preclinical, you had preclinical didactic lecture, and then you went up to clinic to practice for lab. That's your lab. Now you have clinic, and there is no lab except for instrumentation lab. That's your lab. So I get people posting, oh, in lab this week. No, you had clinic this week. Is that making sense? Okay. The lab you have this quarter is anything in pre-clin, where you do in the lab, instrumentation lab. But everything you have this quarter clinically is clinic. Right? Barbara is having a problem with competencies coming back. She's doing a printout for you this week to tell you where you stand and how many competencies we have recorded for you. I know she was working on that. You'll get it this week. But she said she's sending you back too many comp forms, that it's not complete. That means your name, the chart number, the date, the signatures, and your self-assessments. If there's no self-assessment, she's going to send it back. I've also told faculty, if the self-assessments aren't filled out, don't sign the comp form, because the buck should stop with the faculty. So make sure all of those forms are complete. Yes, sir.
Sorry.
Too many chips.
Are we getting any laminated data?
I did talk to Miss Lennon about that too. And I said, where's the laminated sheets? And she said, they're coming. She said, I'm working on making some other change. She had to go meet with the perio department to make sure that perio section, that change, is correct. In the meantime, I gave you all sheets, and you use them in your sheet protectors until she gets those done. Yes.
I have a question, because in like the order of procedure, we have to have the case presentation form done before we do data collection?
No.
Or, yeah, that's where I...
Okay, so this is a good question. She's saying the case presentation form needs to be completed before data collection. No, you have to do it at the same time as you're doing your data collection. So you're checking the tissue and all of that stuff and figuring all this. Then you collect your data, and then you see, okay, what's the data telling me I should treatment plan this for? So once you do that and figure out, okay, the data is screaming at me that I need to do SRP 1 to 3 teeth here, SRP 1 to 3 teeth here, SRP 1 here, 1 whole quadrant here. Okay. Then once you have your treatment plan, then you check with your faculty, you have your faculty check, they'll verify all the numbers, everything. Then they'll go, yeah, I agree with that, I agree with that. I think we should do a whole quadrant here. I think we should do a whole quadrant here rather than the 1 to 3. Then you enter your treatment plan and have it ready to go.
So which part of the case presentation do we finish before data collection? Because I feel like most of it is.
Okay, so that's a good question. Data collection to me is anything that's on that sheet. So you kind of can't do any of that unless you have that. The top part maybe, where it's your medical history and you know, that can be filled out before, like the day before, and then add anything that changed. So that little top section. But if you get new radiographs, you can't do the radiographic eval. If you haven't looked in the mouth, you can't do the restorative or any of the other issues, like saying that they're tongue-tied if you didn't know. And then looking at the tissue, the boxes where you checked each section, those can't be done until you really look into somebody's mouth to see where they're inflamed. And then you can't see how much plaque or calculus or all of that until you look in the mouth. So they're kind of done at the same time. Like when you're looking at that, whoever's charting for you, if you are, you could say, okay, in the upper right quadrant, around tooth number 3, that section, that's real red around that crown. Okay, that's normal, that's normal. This section has blunted papilla. This has boggy, this. And you can do all of that as you're looking in there, starting your data collection, or as you're doing the data. So it's kind of done kind of similarly at the same time until you get all your numbers in. Then you could say, okay, now my treatment plan is, so this right side after data. Okay, make sense? Anyone else confused about anything? Where are these guys? You want to try it? I'm trying to get it up on this screen, this video clip.
Is there a light? Is there a light on up there?
So I'm going to turn it on now. Oh, it's still shutting down.
Sometimes I turn it off.
Okay.
This is VG.
It still wasn't showing.
Oh, it still wasn't showing.
Is it light off?
Let's try.
Now's a good time if you want to take your break. Oh, there we go. Projector. I did all of this.
At least, was this up though?
Yeah.
It was?
But that's not showing it here.
Yeah, I know. Oh, I heard it beep.
I didn't shut it off. Maybe when you shut it off.
Sometimes it just needs to reset, I think. I don't know. I did hear it beep though.
I did hear it beep too.
The point to that other quiz.
I did this morning.
Oh, because my grade is still the same. Maybe
because you did it correctly the first
time.
Okay. I just changed the first two. Once you got it, I just gave everyone who got it incorrect last time. I got it.
I thought I got it incorrect though.
Come to my office with my grade form there.
Okay.
But I gave everybody points this morning.
Okay. Can I ask you a question, or are you busy?
I'm just trying. There the program's on. Okay.
Okay, so later, after class.
Okay. So like that?
Yeah.
There we go. Okay. I am going to make sure the sound is up. Volume up. Let me just play it, see.
Is this a lecture from her?
Able to come in and give you guys an option to talk, so I should be coming out of here. Volume up.
Volume up.
It says max.
Yeah.
Hey, we're almost there.
Last time I plugged this out on Miss Hayton's and then it worked. But that's coming hooking up to your laptop.
I'm going to escape there. Close this out. Your education.
education of your patients. So the first step that we need to
Okay, we're almost there.
Yeah, we got
Where's my
we got video but no sound.
Okay, is this speaker out or mic in? No, it's not a mic in. Is this a mic in?
Try headphones. Or try mic in, yeah, try mic in.
Let's try it.
Hi class. I unfortunately to be able to come in and give you guys an actual lecture in this day's class, so I'm going to
just we got video.
We've got video, no sound.
Is the volume up?
Volume is maxed.
What's volume?
Volume maxed.
Okay. Microphone. Let me look on this. Maybe there's something going on here.
Okay.
Did you? Good job.
Think about that. I told you I
Hi class. I unfortunately am not going to be able to come in and give
BJ said somebody else's computer, they had it happen in half hour and it was
That's why I just
We can look. So, Word or it was web? You were in web, right? Let's put it. That one?
He just fixed that and it's still a problem. Richie did it this morning. So there's, I don't know
we'll be discussing all healthcare and patient education. Obviously, you guys are already on clinic, so you're at the point where you're going to be working through the oral hygiene appointments. And this lecture is to help you give a little bit more background of what you should be doing, what you should be discussing, and how exactly you're going to be able to be more effective with your education of your patients. So the first step that we need to review is assessment. So what makes this patient that you're seeing unique? When we're assessing a patient, we're looking at everything about them. So we're looking at their health history, their data in case presentation, papers that we come up with. We're going to determine the presence and severity of disease. We're going to enter the level.
There you go, here's something.
Sorry, evaluate the level of the patient's interest and willingness to change.
So, JJ, you said it was a short last time?
Well, I did it with Miss Hayden, and she had a max, so when I removed that, it worked.
I did both. Yeah, I know. That's why I was very fast.
I think that was it right there.
When I did it.
I heard the blowing going across. You heard that?
Yeah, no. And I went. No, but you should have seen the second. I didn't get the second one. Everybody called me out. But everybody in the background was like, everybody in the background knows I don't do that.
Sure, let's play Hillsong.
Right back out.
There's something in that presentation It isn't in this, it's in the presentation.
Laid that last year.
So there's something within this presentation that's happening because it's working across the system's working. Everything here is working to that, except for this right here.
Try this. I'm going to try something else, and that is I'm going to go to last year's course. Preclinical last year. See if I can get it. She moved it over. Seminar. Spring of 2018. Let's try it. See, Reggie took care of that this morning.
I'd say he didn't take care of it this morning.
Okay, so there it is. She's talking now from last year.
It's playing.
You hear it? Here's something.
And this lecture is to help you give a little bit more background on what you should be doing, what you should be discussing, and how exactly you're going to be able to be more effective with your education.
To get escape this.
So the first step that we need.
All right. Well, let's try this.
So
Let's start at the beginning. Okay. How do wait. So I need this screen up because they have to be able to see the slides at the same time. I need this up. Big screen, not just her talking because they can't see the slides at the same time.
That will take it down, right?
Just like you covered the same thing.
They should be able to see her. And
You're okay.
What you got, right?
Hey, Noe, we've been thinking about you. You okay? Stop. Okay, so thank you so much, Alan. For some reason, the volume's not really loud on it, so what we're having is a lecture on the oral hygiene instruction competency. After seeing this and having our discussion, it's about 20-some minutes long, then you will be able to attempt that competency starting this week. Okay? So listen up. I've got a bunch of stuff up on the screen so that you can see her and the lecture at the same time. All right, let's try it.
Hi, class. I unfortunately am not going to be able to come in and give you guys an actual lecture in this week's class, so I'm going to be doing it remotely. Thank you for being here for today's lecture. We're going to be discussing oral health care and patient education. Obviously, you guys are already on clinic, so you're at the point where you're going to be working through the oral hygiene appointments. And this lecture is to help you give a little bit more background of what you should be doing, what you should be discussing, and how exactly you're going to be able to be more effective with your education of your patients. So the first step that we need to review is assessment. So what makes this patient that you're seeing unique? When we're assessing a patient, we're looking at everything about them. So we're looking at their health history, their data and case presentation, the treatment plan we've come up with, We're going to determine the presence and severity of disease. We're going to educate the level, evaluate the level of the patient's interest and willingness to change. We're going to determine the current personal health care issues that are in use. We're going to note any limits in dexterity, develop goals with the patient that they agree with. We're going to explain the consequences of not following through with the care plan that we're outlining for that patient. So as you can see, the assessment phase really takes up the first part of the appointment, right before oral hygiene. We're looking at everything, all of the information, all of the data that we've gathered, and we're going to kind of put that together and then create a plan for oral hygiene education. We want to assess the motivation of the patient. What's important to recognize about motivation is that it's extremely complex. It is a person's ability and likelihood to change, which is varying. Patients can be internally or externally motivated. Internally motivated patients generally respond a little bit better and are more effective with their care, or change in care. Externally motivated patients generally are not quite as successful with their change and or breaking a habit. And that's specifically because they're changing for a reason that is kind of outside of them. So they personally do not really want to change, they're changing for another reason. So hopefully in the back of their mind, if they change this behavior, they will get a reward. An internally motivated person recognizes that the reward is just the self-satisfaction of changing that behavior. So motivation includes our expectations, our ideas, feelings, desires, hopes, attitudes, values. All of those together create motivation in an individual. Common motivators that you're going to see in the dental hygiene clinic are going to be oral malodor or halitosis, tooth or gum pain, tooth discoloration, concern over disease development and progression, the presence of bleeding when brushing or flossing, a poor taste in the mouth, or an inability to pay for expensive treatment. So I generally like to tell my patients that, hey, you might not want to get a filling done right now, but if you leave that decay long enough, it's going to be a crown. And a crown is $1,000, and filling is maybe $200. So generally, when we kind of discuss that with our patients, sometimes they're a little bit more open to seeking a more conservative treatment if we kind of expose them to the risk of letting that treatment go, letting that condition go without treatment. Adverse factors that may inhibit change include previous adverse experiences, educational insufficiencies, non-acceptance by peers, poor self-image, impoverished socioeconomic circumstances, and recognizing that motivation is not a personality trait, it's a state of mind. That means that different people can become motivated for different reasons, and motivation itself can be changed as long as a person is willing to psychologically make that effort. We're going to now talk about the stages of change. This is a learning theory that allows us to kind of specifically determine where a patient is in their likelihood or the implementation of a change that they're making in their life. And this can be behavioral. It can be something like improved oral hygiene, or it can be tobacco cessation, changing their nutritional intake. So when we look at this, we have a total of 5 stages. The first stage, the earliest stage, is pre-contemplation. This is where we're really discussing for a patient just kind of the basic reasons why they should consider changing. So all we're doing here is providing information and discussing risks. The patient at this point has no real desire to change and really is not thinking about it. At the contemplation stage, this is when we're going to discuss the pros and cons and really any ambivalence. We're going to discuss here, kind of why the patient needs to make that change. At this point, the patient might be thinking, yeah, I know I need to, but I haven't really gotten around to doing it yet. Preparation is the next stage, and this is where we're going to provide information, support, encouragement, and follow-up with the hope that the patient is going to actually get into preparing to make this change. So at this point, the patient may have decided, hey, I want to quit smoking, I've set a quit date, I've gone and gotten the medication from my doctor that I'm going to need to help me get through it, but I haven't actually stopped smoking yet. Action is when that action, the reduction or elimination of the habit has taken place. Here we want to provide support, encouragement, and follow-up. The action phase normally lasts about 6 months. If a patient stays in the action phase for 6 months, they go into the maintenance phase. When a patient maintains, at this point, the resolution of the habit, this is kind of considered the highest level of the stage of change, or stages of change. And it is here when we feel confident that a patient is going to be able to continue with this pattern of behavior without immediate or constant supervision or encouragement. The patient after 6 months has pretty much broken a habit and they're able to kind of maintain this new behavior on their own. Next, we're going to talk about implementation. So how can you best talk with your patient? Now, we've already talked about the assessment, obviously, but we're going to go ahead and talk about implementation at this point. So how can we best talk with your patient? First thing that we want to discuss is motivational interviewing. Motivational interviewing is huge. It allows us to really get to know our patients and to develop a deep connection with them. It is defined as a collaboration and education with respect for autonomy through use of specific techniques and strategies. It should be non-judgmental encounter. The clinician should be a sensitive and supportive advocate for that patient. What I want to emphasize here is respect for autonomy, which means that a patient should always be involved in decision-making regarding their treatment. You should never make a treatment for a patient and not allow them to give you their kind of response or discuss with them, you know, kind of why this is an important treatment for them. They should always be part of that conversation. When utilizing or implementing motivational interviewing, we like to use RULE, which stands for resisting the writing reflex, understanding motivation, listening well, and empowering. Resisting the writing reflex means that you don't want to jump into your patient's conversation when they're discussing something with you and write something that might be wrong. Instead, you want to kind of save that to the end and then kind of, you know, discuss with the patient how new techniques might be better off for them. We want to understand motivation, recognize why the patient is motivated or why they're not motivated. We want to listen well. So motivational interviewing doesn't just mean that you're talking, it means that you're listening. And we also want to empower the patient so that they feel strong enough to implement this new change that you're wanting them to do. So when we get into motivational interviewing, this is a little bit like the RULE kind of is what guides the process of motivational interviewing. So here I've got a little bit more specific details at each stage of motivational interviewing when we're looking at using the RULE technique. And the one that I really want to just focus on is the reflective listening. So under listening well, we really want to discuss the need for being good listeners. Right now, it's easy for you guys to kind of talk to your patient because you've just gotten all this information and you can just kind of spit it back out at the patient. But what we want to really see you do is to listen to that patient and kind of recognize the specific needs of that patient. So what are they having challenges with? And how can you individualize the treatment that you're going to give to them or provide to them so that it's more effective? So please go through and just kind of be familiar with RULE. We are going to discuss this in the summer quarter in a little bit more detail. This is just to kind of give you a general overview of it so you kind of have a basic understanding of the technique. So again, with motivational interviewing, you should be supporting autonomy. You need to make sure rapport is being built with the patient. You want to encourage trust between the clinician and the patient because if the patient does not trust you, it's going to be very difficult for you to make a change and for that patient to accept your treatment. And then we want to focus on the increasing readiness to change. So we want to make sure that we progress that patient through the stages of change. That's kind of the hope of motivational interviewing, is that if your patient is at pre-contemplation, you're going to be able to get them to contemplation, preparation, and preferably action. Okay? So focusing on that readiness to change is a really important aspect of motivational interviewing. Also within it, we want to make sure that you're expressing empathy. You avoid the development of any discrepancies with the patient. We don't want to get into any sort of arguments. You want to make sure that you roll with the resistance, so if your patient kind of puts up a wall, you need to go with it and don't immediately feel like you need to shut down. We want to support self-efficacy, and we want to elicit change talk. So all of those are really important concepts within motivational interviewing. Also, we want to make sure we're asking open-ended questions. So when you say to a patient, have you ever tried to stop smoking before? They're going to be able to say yes or no to that. So instead of asking a closed-ended question, we want to try and ask open-ended questions like, when you tried to quit before, what was the hardest part? Or tell me about when you had a craving for a cigarette. We can also use darn, which allows us to listen for change talk. Change talk is what we hear the patient saying that indicates to us that they're going to try and make a change in their future. So this stands for desires, ability, reasons, and need. So for desires, we need to evaluate what does the patient want. Abilities, what is realistically possible for that patient to be able to do. Reasons, ask the patient about the reasons for change. Why do they want to change? Need, ask the patient the level of importance for the change. Why do they feel that this change is needed in their own life? Dialogue versus monologue is also an important concept, especially with motivational interviewing, because it's important and imperative, quite frankly, that you discuss and you have a dialogue with your patient, which means they are actually giving information back to you. So instead of you just talking at the patient is a part of the conversation, is helping to lead wherever that conversation may go. Using reflective statements can be very beneficial. You want to make sure that you're listening about twice as much as you're talking, and avoid overwhelming the patient with information. Especially right now, you guys have so much information that you really want to share that with the patient, but we need to make sure that we don't overwhelm them with just too much information to where they just kind of shut down themselves. You can use the chunk, check, chunk technique to avoid overwhelming the patient. This is when you give the patient a chunk of information. You then check to see if the patient understands what you just discussed with them, and then you give them another chunk of information. If they don't seem to understand what you're saying at that check station or that checkpoint, then you're going to have to go back and reevaluate that information that you've just gone over. Re-explain, get some information or some feedback from the patient as to what they don't understand. Once you're sure at that checkpoint that they are understanding what you're discussing, you can then move on to the next chunk of information. Now we're looking at clinical implications. So how does this translate into a clinical setting? So we've kind of reviewed the need to assess a patient's history, to kind of evaluate their level of motivation, to implement motivational interviewing techniques, and to try and work the patient through the stages of change. But how exactly does that work in a clinical setting? We're going to get right into this now. First and foremost, you need to make sure that you are offering individual recommendations. That means that you should not be giving just basic blanket instructions to all of your patients. You need to evaluate the specific needs of each patient and make sure you tailor recommendations to that. Oral hygiene starts, whether you believe it or not, at the very beginning of the appointment. You need to evaluate the health history, recognize, as we have said, maybe the patient is on a medication that causes neurasthenia. That's going to impact your oral hygiene instructions that you're going to give the patient later on in the appointment. You also want to recognize any obvious limitations the patient has. That might be broken bones, advanced arthritis, missing digits, neurological impairments. All those things are going to be kind of challenges that you're going to have to overcome so that the patient can still make or practice good oral hygiene skills at home, even with these restrictions. You want to complete your necessary radiographs and evaluate them. Obviously, that's going to help you determine if your patient has gingivitis or periodontal disease. You want to complete your data and get that obviously checked by your faculty and create a treatment plan based on that. You're then going to complete your plaque score and evaluate any patterns in that plaque score to see where is the patient missing when they're cleaning at home. You then want to evaluate all data comprehensively to determine any areas where the patient is struggling and areas where the patient is doing well. You can at this point begin formulating a plan for what tools need to be taught or given to that patient. So it's important to see, OHI is very comprehensive. You have to evaluate everything that you've gone through and all of the data that you've gathered from that patient since they pretty much sat down in your chair. I have some recommendations here for you that are very, very generalized, and I want to emphasize that this is not addressing the individual needs of the patient. Okay? These are just kind of some options that you could recommend to your patient. So in an AAP1, you might want to recommend fast brushing, C-shaped flossing, use of mouthwash, maybe floss picks, toothpicks, and maybe gingivitis inflammation and periodontal disease prevention information. Remember at AAP1 they don't have bone loss, so we're looking at gingivitis at that point. Here's when we really want to focus on technique. Really understand how you brush and floss to prevent developing periodontal disease. Then we move into an AAP2. Here we can also do fast brushing, C-shaped flossing, mouthwash, floss picks, and toothpicks, but you might also now want to recommend gum soft picks, maybe an end-tuft brush, and begin discussing periodontal disease because at AAP2 they do have 0 to 25% bone loss. So they have periodontal disease at this point, and we now need to make sure that the patient is aware of that and doing what they can to prevent that periodontal disease from progressing. At the AAP3 level, we might want to discuss electric toothbrushes, maybe implementing a water pick. Still can use mouthwash, maybe toothpicks still, gum stimulators, end-tuft brushes, inner dental brushes, and more information on periodontal disease infection, prevention, or obviously no longer prevention, but treatment of and maintenance of. At the AAP4 level, we can do the same, but you might want to include things like tufted floss, because at the AAP4 level, there's a good chance we've got furcation involvement, larger embrasure spaces, and things like tufted floss can definitely become a little bit more effective. So what I want you to realize is like, let's say your patient is using an electric toothbrush. If that's what they use twice a day, you definitely don't want to start reviewing fast brushing technique with them because it's not relevant. So you need to evaluate what your patient is currently doing and then analyze what your recommendations are and see how those mesh together. So more specific recommendations. Here I've got just kind of a list of tools that are available on Clinic for the most part that are beneficial and when you can kind of recommend it to your patient. So an end-tuft brush, this is great to use if the patient has erupting wisdom teeth or heavy lingual anterior calculus. You can bend the neck to a 45-degree angle to access the linguals of the anteriors, which works great. Tufted floss, you can use this if the patient has a bridge or implants. Interdental brushes can be used based on the embrasure sizes. Obviously, some are larger, some are smaller, based on the embrasure size. Make sure you give the proper sized brush to that patient. You can use plastic-coated centers for those who have implants. Extra soft toothbrushes are obviously great for patients who are prone to recession or those with inflamed gingiva, but do remember we should always be recommending soft toothbrushes anyway. Water picks can be used for patients who have ortho, limited dexterity, large hands that kind of inhibit the ability to floss, or patients who just shut you down on being willing to floss. Tongue scrapers can be good at reducing oral malodor, reducing staining, and getting rid of coated tongue. The Reach flosser with a handle. These are great to assist patients who struggle to floss in the posteriors. They're great for those with very limited dexterity or large hands. Gum chucks can be used to assess children learning how to floss. And I'm sorry, my voice has just got allergies and it's just a little bit raspy here. Disclosing tablets can be given to patients to allow them to kind of see how their own oral hygiene technique is working at home. Perio-Aid is very beneficial for removing the plaque of the gingival margin. Electric toothbrushes are beneficial for those who struggle with proper brushing technique or do not brush long enough. They're great for those who have caretakers that are brushing their teeth for them. More specific recommendations, you can recommend Paradex. Although remember, it needs to be recommended on a very limited basis because it can cause staining. But it can be recommended for ANUG, ANUP, short-term caries prevention, or post-perio surgery and extractions. MI paste can be utilized for remineralization, white spot lesion reduction, and desensitization. Biotine products can be used. They help a lot with, obviously, xerostomia. They have mouth rinses, toothpaste, and gels available, along with a few other methods of delivering the biotin. Xylomelts can be used. They're an alternative to some of the more common xylitol gums or mints. And they work well at reducing xerostomia, and they're actually anti-caries. So they're a great product. It just kind of, the patient will adhere it to their, the buccal surface of their first molar. And when they sleep or use it during the day, it actually encourages the secretion of saliva. So the oral hygiene competency. We're going to now talk about how you put all of this together and complete your competency. Obviously, first off, recognize that the oral hygiene competency is a 2-appointment competency. The second appointment needs to be 1 week minimum after the first appointment. You need to recognize the stage of change of the patient, and this may or may not change at the second appointment. At each appointment, the patient should be taught and exposed to a new tool. You should not be reviewing in the first appointment what you reviewed, you should not be reviewing in the second appointment what you reviewed at the first appointment. You can obviously quickly review it, check and see if the patient is doing what they should be, but you shouldn't be re-explaining or re-educating the patient on that same technique or tool. The patient should demonstrate the taught technique and tool intraorally. You should provide modifications if necessary. Radiograph should absolutely be utilized to describe periodontal conditions. Periodontal disease should be described or explained using the visuals, such as the chairside manual that you all have. The large typodont should not be relied upon, as it is unrealistic. So you can utilize it, but do not give the large typodont and brush to your patient and say, can you show me how you brush on this? It's massive, and it is not any way realistic to how the patient actually brushes. This is an excellent time to describe the specific treatment that is recommended. So if you're going to discuss that, maybe you're doing scaling and root planing, this is a great time to discuss periodontal disease and to kind of further educate your patient. So what not to do. Do not review brushing techniques when the patient uses an electric toothbrush. Do not recommend C-shaped flossing if the patient has poor manual dexterity. Do not use your radiographs. So not addressing or referring to or utilizing the radiographs is not a great way to fully educate that patient. You want to make sure you provide oral hygiene instructions with the utilization of a plaque score. You cannot do OHI and not have a plaque score. Do not provide blanket instructions to all patients. Do not focus only on brushing and flossing instead of looking at alternative tools and techniques. There are so many different tools and techniques that are out there that if all you focus on with your patient is fast brushing and C-shaped flossing, you are really almost doing them a disservice, because brushing and flossing is well known, but soft picks and tough brushes, those are not well known, and they're something that can really aid that patient. Disclose the patient's teeth, or what you should not do is disclose the patient's teeth and not allow them to brush before you dismiss the patient. So if you're going to do OHI and then dismiss the patient, please make sure that they have time to brush their teeth to get the purple off before you send them off, to go back to work. Use of PPEs. You need to be careful about avoiding cross-contamination. Do not contaminate your typodonts, your toothbrush, your floss, or your informational manuals. You need to really, really be careful about this. Don't talk to your patient with your mask or your loops on. If you're going to sit there and educate the patient, take the mask off, pull the loops down. The patient is going to want to actually be able to see your facial expression, and it seems more personable, and you're going to develop a better rapport if you can actually talk with and see that patient's, if the patient can actually talk to you and see your face. However, do not demonstrate intraorally for your patients without putting your PPEs back on. So utilize the first portion of the appointment as your education phase, where you can kind of discuss without your PPEs on, kind of review the different concepts and techniques, then put your PPEs on and go ahead and demonstrate intraorally with that patient. Your mirror needs to be cavity wiped and then dried. Do not use a dirty spotted mirror. If you do not dry the mirror off, it gets super spotty, and when you hand that to the patient, it looks really, really unprofessional. Okay, so that is pretty much all that we have to review at this point. I hope that this gives you a general idea of how to complete this competency and be a little bit more effective with your education for your patient. Now, we're going to be going into a lot of these different learning theories and techniques in my class, which you'll have in the summer, fall and winter quarters. So you will get more information, so I don't want you to panic and feel like you're not quite familiar with all of these, the stages of change or perhaps the motivational interviewing. We will review this at a later point, but I want you to just kind of be aware of what exactly is expected of you when you really educate the patient. And really what that is that you should be comprehensively reviewing all of the information that you have obtained from that patient and making sure that you individualize your recommendations based off of that. If you do that, you're going to be sure to provide quality education and instructions to that patient that they're going to be able to implement into their day-to-day routine. The hope is at that point that you're going to be able to assist that patient in preventing either their gingivitis or periodontal disease from progressing any further. If you have any questions or concerns, please don't hesitate to ask or request assistance from any of your faculty on clinic. If you have any personal questions specifically that are related to this lecture, feel free to email me and I can go ahead and answer any of those concerns that you may have. Hopefully this lecture goes through relatively decent and you guys can kind of benefit from having a lecture but me still not being there at the same time. And again, if you have any questions or concerns, please feel free to shoot me off an email. Hope you guys have a wonderful rest of your day and hope that you enjoyed this lecture.
Cool. So a couple of things have changed a little bit. She didn't want to record this. The first thing is, the AAP case types have changed, so that's a little bit different. So what would be normal, you would be case type 1, and then so it's backed up by 1. The second thing is, you will not have her this summer. Your new faculty for teaching community is going to be Mrs. Loomis. So she's going to focus just on senior clinical advisor, and Mrs. Loomis is going to take over community. So that will be changing. Are there any questions that you have about the oral hygiene competency, AJ?
So if we are attempting this competency, we're not going to be, this is just a strict oral hygiene instruction. So we're going to be
read the competency form and see what is expected of you. It's posted online. You should have a copy of that. If not, in the little office there where all the comp forms, you can grab one of those and really review that before you attempt your competency. Rachel?
So we need a patient 2 times this quarter to get this comp this quarter.
Yes.
So, but we can have a patient 1 time this quarter and 1 time next quarter.
You could if it's towards the end of the quarter.
Yeah.
And then you jump over 1 and 1. Yeah. You could either do it 2 times this quarter, which will work, or 1 this quarter and 1 next quarter.
And that would work.
Yes.
Okay. So the second time the patient comes back, would they, what would they be coming back for if you finish the appointment first?
Either just that, or you're not finishing your appointment, and that's a good person that you're going to collect data, and I'm going to start my OHI competency.
Okay.
Yes, Sandra.
What if you start on a patient and they don't come back?
When you don't get the comp, you got to do another one. Yeah, sometimes that happens because somebody doesn't come back, something happened to them, they died. I mean, you never know. We've had somebody that's happened to some of our older patients. You just never know what's going to happen with them. So, yes. Any questions on the OHI? Do you see why we didn't want you to do this right at the beginning? Yeah, you've had some oral hygiene lectures and you know a little bit about how to give some instruction, but using the different tools, answering the questions about where they are in the stage of change, all of that stuff. So now you can begin doing that. I would at some point maybe re-watch at least a portion of this. It's under Panopto on your left side of your screen.
Is it under
Winter Junior Clinic Seminar?
Seminar. It's on the left side. It says Panopto, where you can choose modules or whatever else. You should be able to watch it there. Okay. Any other competencies that you have a question on, or you're just not sure what to do? The ultrasonic comp, I'm going to tell you, it's pretty easy. You set it up, but make sure somebody's watching you set that up. Then they're watching you doing your scaling with the ultrasonic, and they're watching you disassemble it. If those three components are not there, they're not going to give you the competency. So Sunshine.
For that competency you're talking about, I know we have to flush the lines before and after. What exactly does that mean to do before? Clean, so is it clean, air, water syringe?
No. So when you're flushing the lines before, that's running the air water syringe like you would your air water syringe. You're just stepping on the pedal and the water's flowing.
running it for
for 2
the
minutes.
second time when you put it up to the.
And then when you're cleaning it out, you're blowing the air through to clean all the water out of the line.
Okay.
Yeah. And they don't have to have a whole lot of heavy calculus. It's mostly deep plaquing, but if they have some calculus, great. If you've already gotten your ultrasonic competency, let's say spring quarter, and you want to attempt a second one, now this is a senior comp, so you must have some significant calculus. Okay, so if you've already gotten your ultrasonic comp and you do a second one, have some significant comp, and that's part of your senior competency. So everything rolls over. If you do 2 IAs, you pass them both. You get one for your junior year and one for your senior year. Sunshine?
So on the X-ray one, the
Radiographic eval?
Yes, the radiographic eval. So, like for me personally, I've already gotten mine done, but we ran out of time. As far as I looked at the X-rays.
Okay. Just have somebody on a day that you have available to go through that with you.
And then when's a good time though? Because I feel like
When the faculty isn't busy, so a really good time is after check-in and when everyone's doing data.
Okay.
You know, if you ask me at 11:20, I'm going to tell you no. Okay, because everybody's checking out, but you don't. It's strategic when you do that. So a lot of you have been attempting the radiographic eval. It's great. What I have been noticing this last week, but I think the word's getting out, that I don't just want you to write C, A, RPD, or C, because I need to know what tooth number, what the material is, and what surface. So for example, it should say the amalgam AM, tooth number 3, amalgam MOD. In that, I need to have all 3 of those components there. Or if it's a bridge, either removable partial or a fixed partial, FPD, and you have to have all of those for each one of them. Is that pretty clear on that? Now, the charting of existing restorations, that's when you are doing it right in somebody's mouth. So I'm going to chart what I see. I see a composite MOD. I'm going to draw it on the tooth. That, you can use your x-rays too to help you if you don't know. But the charting is what we're looking for. Did you color it the right? Did you hashtag it if it's precious metal? Did you color it in solid if it's amalgam? Did you leave it open if it's a composite? So that's a charting of existing restorations. 2 different ones. Radiographic evaluation and charting of existing restorations. So that's pretty much all the competencies. I think we've covered all the x-rays, OHI, and charting of existing, and radiographic eval, and the FFX. Okay, so, and the 5 injections. Any other questions? No clinical questions? Okay, then I'll let you go.
It's okay.
Oh, you know what? I have a question. Noe, if you could step out for a moment. Thanks. And then I've been grading quizzes real quick. See out the door? Okay. So what I've been noticing is the question that says, we must always treat the patient's chief complaint. Okay, we must always address the patient's chief complaint, but we don't always treat it. For example, if their chief complaint is whitening, and that is nowhere in the plan, whitening, so it's addressing. Most all of you got an extra credit, so you end up with the full points, but and the second one is a lot of people put for the if the patient has had scaling and root planing and has come back for a regular recall appointment and there's no periodontal changes, like it's not worse, what likely is the treatment plan? I have some people say it's back to a prophy. No, it's not back to a prophy. And some people say it's a periodontal reevaluation. No, they've already come back for their recall now, so they're recalling again 3 months later. This is a periodontal maintenance cleaning. Does that make sense? Okay, good job.
Leslie, I have a question. I'm bringing my parents this Wednesday for me and Naveen. So I was wondering if they arrive here around 11, can we do x-rays on them before?
They won't let you take an FMX at 11. It's too late.
But is it like if they come earlier? Can you take an FMX if your clinic starts at 1? Yes?
Yeah, as long as Dr. Jewell has approved it.
I know. Can they come at 10?
Is it okay?
That's outside of clinic time, so you can do what you want. If there's an opening and there's no class,
Do we have to make?
You have to ask
The radiology.
Dr. Jewell has to order it, and then you have to ask radiology if the chair's available.
Okay.
So they may come and they may not.
Miss Lee?
Where's Noi? I need to see Noi. Don't go away.
Miss Lee, if
Yes.
I did a full FMX last week, who do I give the form to grade me?
The grade form, they have it. No, it's the one that they use for the grade
So they're the
sheet.
ones that are going to grade me? Oh, okay. And then I give them the comp paper also?
Comp paper is
that? Oh, okay. Okay.
Noi, can you do this for me? Thanks. Yes, ma'am. How are you doing? Is it getting better?
With everything, yeah. I'm sorry, I didn't meet you on Friday. It's
It's
okay.
okay.
But I will send an email to meet with you this week.
Okay. Do you have time? Like right now?
Do you have time?
Yeah.
I do, okay.
Okay. Yeah, we can do that as soon as he's done with his
Okay,
quiz. I'll
I can
have
wait.
him. But yeah. Sure. Now's good.
Because I know Tuesdays you're not here. And then,
Wednesdays I'm in clinic all
yes,
day.
with us. Mm-hmm.
Is there any more chips left? I have to wash those bowls.
Oh. Is this where we get the TV? No.
Oh, I don't think so. These chips.
For what?
Chips? Oh, Chile limon.
I mean, come on, nice to meet you. Okay. Oh, this is good. This is good.
That's it?
I'm serious.
How can you eat that
I'm a
little?
woman on a mission. All right. Thank you.
I probably need chips.
I could come on Thursday or Wednesday. Okay. What time? We're open on Tuesday, usually by 5. But I have to be somewhere at 6.
No, okay.
So.
You're not? Work on the case thing?
It would be like 8:30. Is that okay on Tuesday? Yeah, 8:30 on Tuesday. Oh, we don't have. Yeah. Yeah. And even if it doesn't, I usually.
I was up at like 1 o'clock and Miss Lennon was grading things and I was getting notifications on Canvas.
I'll come
and I
right
was
back
like,
here.
Night owl.
Yep, we're all night owls, but I can
So actually, yeah, Tuesday at 8:10 to 8:30, and if that doesn't work out, then just like 2 hours. Okay. Okay, perfect. Yeah, I can do that.
Just on like, oh yeah.
Yeah, I can do that. Yeah. Okay. Yeah, I'll text you to remember.
Okay. Oh, I was gonna get somebody else. Who is this? Kayla.
She just stepped out. She'll be back though.
Oh, she's here?
Yeah.
I need her to do this. She did this incorrectly.
Oh, wow.
So do I. Actually 5:30.
I usually eat between 6 and 6:30. It makes me really hungry. Did you do 2 on the bottom? A and B? That's a cool pen.
Oh, the bone.
Yeah. Do you want some more chicken?
Oh, okay.
Okay, did you get chips? Have some. You missed my workshop. Somebody will have to tell you about it. Are you okay? Everything's good?
Yeah.
Is your car any good?
That's what they're trying to figure out. They're saying it's not up, but.
Chile lemon and it's fine.
Thank you.
You're welcome. Just scoop it up.
Okay.
Take a lot because I really like stuff. Look at all. Put the whole thing.
So you're gonna have to get What sucks is like I just got this car.
You did? Is it new?
Well, it was a used car, but still I just had like a month to keep it.
Oh, wow.
Is it your fault?
No, they cut me off. So it's smart. They got in my way. They hit me.
Like they sorted to your thing? Oh.
Okay, I'm ready. Do you need help?
Oh, yeah.
You have your stuff.
No, I'm gonna leave it here.
Are you?
We have class.
You're
Oh, okay. Give me that. I'm gonna take my stuff here. Kayla. Tell her I need her to come to my office. Hannah.
Okay, I will.
Thank you.
Yeah, they'll be, I think they just went to the bathroom. Oh, okay. They could be.
I'm trying to say it's a lot. But how old is she?
What do you do?
and he has to pay it back.
Oh.
And I'll be right back.
Okay.
But you should have told them everything is fine.
There's just the only thing he was still to it.
Because the hood.
Tired.
Oh, I see. So the hood like caved in.
Yeah.
But could it still run?
Yeah, it was running.
Okay.
What was it?
Was the other person blaming it on you?
Yeah.
Oh.
Here's the other thing. It was me and some other car, and then the guy that caused it. And the guy that caused it left his information and drove off.
What?
So you and the other car though were like, yeah, it was him.
Yeah.
That's good.
So we're still gonna see.
Was his car damaged, the one who caused it?
No, he just got like a little scratch. My car came out the worst.
And then the person behind you hit you also, or what? Kind of like it.
Yeah.
So, you like call cop?
Dude showed up in like less than 5 minutes.
Oh, really?
Yeah.
Shit. So,
Yeah, to me it was somewhere there already. They saw that there's an accident and showed up.
really?
Yeah.
Like you didn't even call me, you just showed up?
Yeah.
Like on the, were you on the 9, the 10, 91? Oh, yeah. Oh, so you take the 91 to the 10, right?
And then I have to take the test tomorrow at 7.
Oh, you hear about it? Or
Huh?
you hear anything about the test?
No, I really don't know.
It was literally everybody failed.
Live.
Like, no, okay. So when you finish, it like gave you what you got. Like it gave you your score. And so I finished and I got 27 out of 40 and I was like, what?
That's pretty
And
good.
I went out into the hallway and then like there were already some people out there and I was like, what'd you get? And then it was like, dude, I got 24. And Ken was like, I got a 22. And Trish was like, yeah, I got a 24. And then like literally all of us out there in the hallway, I think AJ was the highest, he got a 31.
Wow.
And then Grace got a 28, and then I had a 27. Naveen got like a 22. Jessica, like there were like 22 of us out there that all were like failed it. So yeah, it wasn't. No one did.
The high was 31. Okay.
That was the highest, 31?
No, I think Catalina got like a 34. I think Catalina got a 34th, but Catalina was the highest one, and it was like a 80%. So I think he's gonna curve it because
Yeah.
all of us out there were like, dude, what
It's
the?
like 600 slides.
Yeah.
Go over, and then there's like. almost
You're gonna
1,000.
start taking it and you're gonna be like, what the frick did I even study? Like, is this the same class? Like, it's not. It's the same.
Okay, I read the book and everything, and even then I was like, this is too much.
Yeah, when he said, his aide was telling us to just study the PowerPoint, and then at the end after the test, he was like, everything came from the book, so, yeah. I just wouldn't worry about it, like, if your score pops up and it's awful, like, everyone did awful, so he'll probably curve it.
Well, you can now aim for a 20 or something. 20, between 20 and 30.
Yeah, then you're good.
That should be fine.
If you get an 11, you suck. Bye. If you got an 11, I'm so sorry, you don't suck.
Oh, no, I didn't get the look. So did he say he was gonna curve it? Or-
When I asked him, he said he would see, but I feel like a curve is inevitable. Like,
Yeah.
if the class average is like a 67, like that, when last year the seniors had open book tests and everybody got 100% like in the class, so like
the same professor or different?
no different professor. So it's like it's not gonna.
Yeah, that's.
It cannot not be curved.
Yeah.
already done with it. I don't know, Kayla, I asked Kayla, I was like, oh, we're staying here. And she's like, yeah, but I need to go find sunshine. And I was like, okay. And she's like, I'll meet you in the bathroom. Okay. Went to the bathroom, she her a few minutes, then I walked out. And yeah, I haven't seen her since. Okay, so I'm basically like the starter of it, right? Like I start a position,